Imagine having a terrifying, intrusive thought screaming in your mind. To silence it, you perform a specific physical action. It works. You feel a brief sigh of relief. But performing that action guarantees the thought will return, and next time, the obsession will hit even harder. World Health estimates rank OCD as the seventh most debilitating illness on Earth, placing it alongside cancer and asthma in terms of total impact on a person's life. It affects up to 4% of the global population. The disorder operates in two halves. First, there are the obsessions, the unwelcome and distressing images or impulses that repeatedly enter the mind against a person's will. Then there are the compulsions, the behaviors or acts that a person feels driven to perform to make that distress go away. Here is the central neurological paradox. When a person executes a compulsion, the brain receives a brief window of relief, but that physical act reinforces the obsession, signaling to the brain that the original fear was valid and requires even more vigilance. This creates a self-reinforcing trap. The brain's desperate attempt to find safety through a ritual becomes the very engine that keeps the disease running. To begin breaking this cycle, clinicians use the Yale-Brown Obsessive-Compulsive Scale. This diagnostic tool shows that compulsions like checking locks, repeating numbers, or seeking perfect symmetry do not exist in a vacuum. Deep beneath every compulsion lies a precise, catastrophic fear. A person might believe that if they don't count perfectly, they will harm someone they love, or that a lack of symmetry indicates a total moral failure. The behavior is a shield against an imagined disaster. Clinical assessment focuses on identifying this exact root terror. Without pinpointing the specific fear that drives the ritual, the behavioral loop remains locked in place. Moving from the mind to the machine, we can zoom deep inside the brain to see the physical circuit that governs this response. The cortex perceives the environment. The thalamus gatekeeps sensory information. The striatum handles action selection. Together, they form the cortico-striatothalamic loop, deciding when to act. In OCD, this loop becomes hyperactive, stuck in constant alarm, screaming a go signal for compulsions. Brain imaging confirms this hyperactivity. When patients are exposed to a trigger, like a towel they believe is contaminated, this exact loop lights up with intense metabolic activity in fMRI and PET scans. These metabolic patterns reveal a physical alarm system locked in the on position, operating independently of the person's conscious intentions. Traditional chemical treatments struggle to quiet this alarm. For example, research shows that cannabis fails to reduce acute OCD symptoms or the associated anxiety. SSRI antidepressants are commonly prescribed and can dampen the circuit's activity for some, but many patients find the underlying severity of their symptoms remains largely unchanged. There is also transcranial magnetic stimulation, which uses magnetic coils to physically interrupt the motor areas of the brain. While it can disrupt the automatic nature of compulsions, it is often most effective when paired with other therapies. Because OCD is a deeply entrenched behavioral circuit, a purely passive fix is rarely enough. The brain must rewire itself through active resistance. Dr. Helen Blair Simpson at Columbia University focuses on the primary clinical intervention for this rewiring, exposure-based cognitive behavioral therapy. This therapy uses a method called ritual prevention. It requires the patient to deliberately enter a state of high anxiety and then do the exact opposite of what their brain is screaming for them to do. A patient might be brought face to face with their ultimate fear, such as being forced to sit near a contaminated towel. This intentionally evokes the obsession and triggers a massive spike in autonomic arousal. While the brain demands they wash their hands to relieve the stress, the clinician instructs them to stay in that experience without acting. They must endure the peak of the fear without the safety of their ritual. The goal is for the patient to experience their maximum anxiety and discover that it can eventually subside on its own without the need for a compulsion. By surviving this peak distress without acting, the patient teaches their brain a new biological rule, that the anxiety is not a command. This resistance physically weakens the hyperactive cortico-striatothalamic loop. Over time, the circuit slows down and returns to a steady, balanced state as the brain learns to tolerate the signals it once found unbearable. Research data confirms this effectiveness. While SSRIs show a moderate reduction in symptoms, exposure-based therapy produces a much more dramatic drop in the severity of the disorder. Lasting relief comes from proving to the brain that it can withstand its own high-intensity distress signals without the need for a protective ritual. Over time, this tolerance is what finally breaks the loop.